Hello and welcome to this edition of i3 Health's Additional Advances. Today we are joined by Dr. Christoph Carell, who recently chaired an educational activity on addressing positive, negative, and cognitive symptoms of schizophrenia. In this interview, Dr. Carell will discuss updates and the relevance and importance of educational material on the topic of staying up to date with the latest strategies for treating schizophrenia. Thank you so much, Dr. Carell, for joining us today. It's a pleasure to have you. Would you like to begin with introducing yourself and what you do?
Sure. Thanks for having me. I'm Christoph Corell. I'm both a professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York, and also professor and chair at the Department of Child and Adolescent Psychiatry at the Charité University in Berlin, Germany. And I'm a psychopharmacologist interested in early recognition and prevention of illness. That's why I became a child psychiatrist in addition to being an adult psychiatrist, but also treating people with severe mental illness with pharmacologic treatments, and then being involved in clinical trials, real world evidence, and also physical health and mental health.
Terrific. We're definitely excited to have you back to talk to you and get to hear about your expertise. To begin, what are positive, negative, and cognitive symptoms of schizophrenia, and why is it important to know these differences?
Schizophrenia is a complex illness that has different dimensions. And at the moment, we parse them into the three main ones: positive, negative, and cognitive. Now, positive doesn't mean it's a good thing. It means a surplus. It's too much. The things that you and I should not have. Delusions, so that's having mostly faulty beliefs that can't be reasoned about, even with rationality, that are held with strong conviction. Hallucinations, which are sensory perceptions without actually a stimulus. And then also the problem with either thought disorder or disordered behavior. And these positive symptoms are very much at the forefront of what we treat, because this is what brings people into the hospital, what makes them feel so suspicious and potentially threatened that they become angry or act out certain things or withdraw. That's where we have also treatments with the dopamine blocking agents. Now, negative symptoms are, on the flip side, those symptoms we should have that are absent, and we often call them the five A's. We have the experiential ones that may be more relevant for functioning. That's anhedonia, amotivation, and asociality, both active and passive asociality, social amotivation. And we have the expressive symptoms, which are either alogia, not saying much, talking much, or affective flattening. Now, they have been very much associated with poorer functioning, because when positive symptoms are treated, then that's residual. Now, if you have treatment-resistant positive symptoms, it's hard to function also. And then cognition is not part of the current criteria for schizophrenia because it's so hard to measure. But we know that it's really present in maybe 80% of patients that have schizophrenia. And it's most likely schizophrenia is the most pan-cognitively disabling disease, and that has different dimensions: attention, verbal memory, also visual memory, executive functioning, processing speed, as well as social cognition, knowing what other people think about you or what you might think about them. So knowing these differences gives us different treatment targets. Even though positive symptoms are the mainstay for medications, we can treat cognition and negative symptoms by removing side effects of medications, by treating depression, but also by adding cognitive remediation or aerobic sports. So it's important to know these dimensions.
Why would you say it's important that the multidisciplinary healthcare team participate in educational opportunities such as this activity about addressing these symptoms?
Well, the patient doesn't exist in isolation, hopefully, and they have connection with different people. So we should also educate family members and friends about these symptoms and how to deal with them. But doctors and nurse practitioners, physician assistants have very limited time. The overarching team is composed of therapists, psychologists, nursing staff that spend much more face-to-face time with patients and can pick up on these symptoms and then also maybe address with some non-pharmacologic suggestions these symptoms that are still interfering, understanding also whether the patient has burden in terms of subjective or objective functional burden, and can also then liaise to the prescriber that there are certain issues they need to look into.
Definitely. And what is the most critical educational pearl you would share to clinicians to help them improve adherence with their patients?
Yeah, so adherence or non-adherence is a really big issue. And that's the sixth A that I hadn't mentioned. And it's another dimension of schizophrenia that's not part of the DSM criteria or ICD criteria, and that's anosognosia. Now, that's a highbrow word for not really being aware of that one is sick and needs medication. I mean, Javier Amador, who was the Pope on insight, now doesn't call it insight anymore into illness. He calls it awareness. So it's really a neural network problem. We know that people who have anosognosia, partial anosognosia, are harder to treat, don't respond as well, have more negative symptoms, more cognitive disability. So we need to then roll with the game. And I think the main pearl for me is don't engage in the disease talk. Oh, you have schizophrenia. You need to take this medication. I don't have schizophrenia. Well, what about symptom talk? Last time we talked, you said you want to stay in the basement with your parents, but when you were so much hearing voices and you thought somebody was out to get you, you felt even your parents were part of this. You threatened them with a knife and they had to call the police. They are afraid to bring you back in. And your best friend doesn't want to talk to you anymore because you also involve them in these thoughts. Oh, yeah, you're right. Do you want this not to happen again? Yeah. So this medication might be able to help you with exactly that symptom. So not you're psychotic, I treat your psychosis. No, I want to treat the symptom and the associated halo into your life's functioning and into your goals. So that has to do with motivational interviewing and shared decision making, but sharing the decision with a patient that is informed and not with the illness that says, I'm not sick. I don't want to take this medication.
Kind of on the same topic of education and what you hope clinicians go home with, what are some take-home messages you hope healthcare providers who participate in this activity leave with?
Well, I think the take home message is schizophrenia is complex, but you can parse the dimensions into positive, negative symptoms, cognitive dysfunction, and as anosognosia, and understanding where the patient is in terms of severity and treatment needs in these areas, and how these symptoms then interfere with either subjective well being and or functionality basically drives the treatment plan that you will develop. We have medications for some of these symptoms. We have psychosocial interventions for others. And we have also the therapeutic alliance and relationship. Maybe some peer counseling can come in order to help patients see that medications can be helpful. But without adherence to a treatment plan, it's hard to treat patients. But you only get adherence when they buy into the treatment plan. And for that, you need to meet them where they're at with their wishes, their understandings, and then link that experience and expertise that they have with their lives with our experience and expertise we have with treatment.
In conclusion, do you have anything you would like to say regarding staying up to date and educated on this topic?
Well, we all need to learn. Lifelong learning is great. And I think being in medicine and psychiatry, especially where there's so much uncharted territory in the brain and treatments and approaches, it's always great to read the literature, but also be part of messages like this, where experts are interviewed, where you have roundtables, where you get some also online content, going to meetings. I think as multi-pronged as possible that you can get it on demand, but also maybe in in-person meetings is very important that we stay up to date and also interact not only with experts and speakers, but also with our peers that have a great knowledge base that we can tap into.
Awesome. Thank you so much, Dr. Carell, for your time today and your sharing your expertise with us again. We really appreciate you.
Thanks for having me.